Good afternoon, and thank you for joining PQA today for today's Quality Forum webinar. My name is Richard Schmitz. I am PQA's Senior Director of Communications and moderator for today's discussion on electronic prescribing quality optimization. Before we begin today's presentation, I want to mention three important upcoming PQA opportunities for you. First, we have two measure development opportunities for PQA members. Now through next Friday, March 8th, applications and appointments are being accepted for a stakeholder advisory panel for measure development and a new measure development team focused on use of medications to prevent cardiovascular outcomes in persons with diabetes. So check your emails for details, speak with your PQA key member contact, and additional questions can be sent to PQA's Jake Galdo at jgaldo@pqaalliance.org. Second, our next Quality Forum webinar will be 2 weeks from today on March 14th. That forum will present a soon-to-be-unveiled medication access framework for quality measurement. That framework is a product of PQA's Access to Care Roundtable. And then the PQA annual meeting is May 15th through the 17th. We posted this week an updated agenda with session descriptions and speakers. Please check that out, and we hope you will join us in Baltimore in May. Some quick logistics for the webinar. Please submit your questions for our speakers using the questions feature located on the webinar control panel. At the end of today's presentation, we'll cover as many questions as time permits. This forum is being recorded. A copy of the presentation, slides, and recording will be available through the member portal of PQA's website next week. We also have a brief survey for you at the end of today's webinar. We're particularly interested in your ideas for future webinar topics. So with that, I will now introduce today's webinar presenter. Larry King is Clinical Informatics Manager for Critical Performance Improvements at Surescripts. He has more than 10 years of pharmacy experience, including high-volume retail pharmacy operations, change management, system implementation, and healthcare technology development. At Sharescripts, he oversees the quality relationships with key EHRs, health systems, and pharmacies, as well as managing the data analytics team. Unfortunately, Michael Lessard can't join us today due to a child who became ill, but his colleague Rachel Peterson has joined Larry today, and she will help answer questions at the end of the session. So I will now turn things over to Larry to get us started. So Larry, you should now have control of the platform.
Excellent. Thank you, Richard. And I'd just like to thank PQA for having us here today. Certainly excited about the opportunity to talk about optimization and electronic prescribing and where we can move towards that perfect prescription. The goal of today's conversation is to really highlight three major areas. So highlight the key opportunities to improve electronic prescription accuracy. We'll dive into metrics and some of the key areas of progress that we've made over the last couple of years. Really to learn the progress that's made in electronic prescription accuracy through initiatives such as SIG, so the actual directions in a prescription, and the drug description itself. And then lastly, we'll touch on RxChange and CancelRx, two relatively new transactions that are optimizing workflow standards, increasing safety, and really kind of helping both the provider and the pharmacy level. So we'll get into more details of that as we move forward. Before we do that, just wanted to quickly cover Surescripts as a company and who we are, and kind of talk a little bit about the work that we do and why this topic is really relevant. So Surescripts, as our mission, serves the nation as a single most trusted and capable health information network to build on and increase patient safety, lower costs, and ensure quality. So really our mission is looking at the intersection of the EHR, prescriber community, and the pharmacy, and how do we help drive improvement in data across the network. So how did e-prescribing come to be as a concept? Starting about 20 years ago in 2001, two major associations came together of NACDS and NCPA to form Surescripts with a core mission goal of replacing the paper prescription and starting to automate and make electronic prescribing. At the same time, three of the largest PBMs formed a company called RxHub. So that was Caremark, Express Scripts, and Medco, really looking to do very much the same, focus more on the payer and prescribers side of the world. These two companies ran parallel for a long time, and then in 2008, the two companies merged to form a historic alliance under Surescripts with that goal of building a national network connecting clinicians, EHRs, hospitals, PBMs, pharmacies, and technology vendors to sit at the center of the prescribing universe. But more importantly, as we look at prescriptions, really want to spend time in understanding why is quality improvement important, Where do we sit and why is there some issues? And so we have a few statistics that we did in 2017 as a study of electronic prescribing. And some of the things that we noticed from trends is that 77% of medications are e-prescribed, but often there's major opportunities across these prescriptions. We see 10% of prescriptions that need manual intervention, so a pharmacist or technician picking up the phone and calling a prescriber, or having to do something to manipulate the prescription because it's not ready to be dispensed. 10% of the people abandon medication because of cost, and so it's an area Surescripts is very strongly focused on from a transparency and an understanding of what the cost will be. And 40% of patients abandon prescriptions because of prior authorization is required. So I think you can see pretty clearly we've got lots of opportunities to improve on our electronic prescribing, and how do we optimize quality to make sure that these pieces all align together. So we mentioned that manual intervention is often needed on a prescription, but what does that really mean? And so I really want to focus a few minutes on understanding what are the impacts when something goes wrong in the pharmacy. And I think much of these will resonate very clearly with you as providers, but increased phone calls to doctors, increased faxes back to prescribers, trying to manipulate or assume an intent of a prescriber when things are not clear. Obviously, there's major downstream impacts of that of, are you introducing risk? Are you introducing safety issues? Things along those lines. Again, the manual intervention by a pharmacy, most importantly from my perspective, is increased patient wait time, and most importantly, a patient safety issue. And so just to kind of highlight what that means, or what are some of the examples you might see in that world, I think through receiving prescriptions where the directions might be clearly stating, take one tablet twice a day, but you look at a note field and it says once a day for 7 days and then one tablet twice a day. Now, obviously, there's an assumption that the notes field maybe is more accurate, but as a pharmacist having to make that judgment call without having any context clues or any clarifiers introduces an awful lot of risk. So, these are areas that, from a prescription perspective, we have lots of room to grow and lots of room for improvement. So as an industry and as an organization, we've defined a concept called the perfect prescription. And so trying to understand what that means, really looking at the three key players in the prescription and where does the physician, pharmacist, and patient come together to join to make that perfect prescription. And as we think through it, really largely what we're looking at is making an informed decision based on timely and actionable intelligence, promoting the best outcomes, and maximizing a patient's prescription benefits. So a few words really resonate there for me as I think through that concept. And the biggest one is patient outcomes. So where do we play when it comes to safety and maximizing patient care? And then most importantly, convene clearly and accurate to the pharmacist. So removing that opportunity to have to make a judgment call or a guess. Thinking through prescriptions like metformin versus metformin ER, and do we have conflicts between the drug description and an NDC or an Rxnorm, RxQ type ID? So how do you get the perfect prescription? And realistically, we look at three major pieces. One is, how do we know what the problems are? And so our approach has always been convening a network. And so working across our organizations with EHRs and pharmacies and really understanding what are your needs. It's one thing for Surescripts to dictate and create metrics and create areas for improvement, but really it's driven by that network participation. So utilizing all of our key players. The next major step is determining the key pain points. And so going out and listening and hearing exactly what they say, and here are the 35 areas of accuracy that we need to focus on. And then the last piece where we'll talk about here mostly is how do we automate it to monitor these issues? So obviously the volume of prescription trafficking coming across the network is huge. As of 2016 till now, we've done approximately 3 billion transactions we've measured. And so this has to be a process of automated big data generation and done in the back end. And so our approach has been linking multiple data sources to assess quality of electronic prescription. We've created an automatic score system that passes and fails each metric and creates an aggregated score across the network of where each transaction scores. And then really we focused on 35 key metrics that help us determine, is this data perfect? Are we driving towards the perfect prescription? With the end goal of providing insights and analysis on trends to inform better consumer decisions. So as we look across the network, our goal is to drive safety, drive improvement, but without understanding the trend and where the data is showing, it's very hard to drive that message. So again, 3 billion transactions, and 98% of prescriptions across our network are measured with very few carve-outs for compounds or some specialty areas, but 98% of our prescriptions are measured through this automation. As we move forward today, we're going to talk about 4 major topics. So the drug description, or what we'll call the electronic preferred name. We're going to talk about structuring codified SIG, so the directions behind the actual, how do you make it automated, how do you make it codified? And then we'll talk through some of the more new transactions with RxChange and Cancel to talk through how those will impact your practice. So like I said, we have 35 points that we're focused on. We are going to pick 4. And as we bucket these are kind of falling into 2 separate categories. So the first is accurate patient and clinical information. And so we look at that, the SIG, or the directions in the drug description, as 2 of the most important areas across patient and clinical information. And then we're really going to spend a decent amount of time diving into CancelRx and RxChange. And like I said, these are 2 relatively new transactions I'm sure you've heard a decent amount about and have a high level of understanding. We'd like to get down to the details today and really figure out how are they going to affect your workflow. So let's jump into it. As we look at SIG, really, it's incredible to look at where it's come and where it stands right now. So recently, Surescripts did an analysis of 25,000 text strings, so 25,000 prescriptions with directions. And unbelievably, we found 3,797, so almost 4,000 unique concepts. So 4,000 different text strings of directions. And to drive that home even further, of those 25,000, we got down to the level of take once a day. So just the simplest concept of 1 tablet a day, and found 832 different ways that was represented. And to me, that was a stat that really blew my mind, trying to figure out 832 different ways. And it's everything from having typos to spelling out O-N-E versus the number 1. It was really surprising to us. So as you think about it and extrapolate across that 3 billion number of the number of unique text strings that are out there, and what should be a relatively simple concept of 50 different text multiplies into millions and millions of different text strings a day. So really, really hard to wrap your head around. What I would say through this is that Sharescripts has worked very, very closely with the organization NCPDP on what they call a SIG task group. And we're driving to figure out how do we systematically codify these medications. And so through that partnership, we've identified 25 direction concepts, so SIG concepts, that if they're programmed in through the medical record or EHR company, will account for 50% of your text message string. So 50% of the prescriptions coming into the pharmacy will have a codified, automated, very simple to read for the system, for your pharmacy dispensing system, to interpret the SIG and populate it across the prescription. Why is it important? So if you receive a codification, one is automation. So can the pharmacy dispensing system consume that codified SIG and auto-populate into your prescription dispensing system? Less technician intervention, less pharmacist intervention, 2 major benefits. So how do we improve workflow, save time? And then the second is safety. So, it's vastly known the more human intervention, the more risk there is for a misinterpretation, a safety error. So as we go down the road of structuring codified SIG, we get a lot of really interesting questions, a lot of topics that come up. And one of the questions we get all the time is, that sounds great, but how is the prescriber going to do this in the clinic? It's going to add more clicks. It's going to impact their workflow. It's going to add time for them to codify it. And that's probably one of the biggest misconceptions about what we're pushing for here with structuring codified SIG. This is a process that's done on the back end through the software that the doctor's using to take the directions the doctor's already putting into their system and sending the codification over to the pharmacy automatically. So just really important to call out that the doctor doesn't see it, and quite frankly, the pharmacy won't see it either. It's all done through the software vendor system. And so you're not going to see a 1QD come up on your screen, but through the codification process, it automatically will put into patient-friendly text on your screen. So that, again, improving efficiency and improving safety as well. As we pivot from structuring codified SIG and start to look at the drug name, we had very, very similar learnings. And so in a recent study looking across a very simple concept of warfarin 5 milligrams, a drug that's not available in extended release or not available in osmotic or 12-hour or anything on those lines, it's just a 5 milligram tablet. We found over 30 variances in the drug naming convention. And as you can see on the screen, this was everything from branded, branded generics, the strength being 5, 5.0, bottle sizes, parentheses, different orders. You name it, it's in the drug name. And so Surescripts as a company, and then working in very close relationship with drug compendias and the EHR, is working to move forward a concept called EPN, or electronic preferred name. And we'll talk about what that means in a second and how that can improve. But I think just kind of taking a moment here to pause and just let that sink in, of everything on the screen is the same concept, but can be consumed differently, and understanding, from a human eyes reading it, you understand it, but how do we make this safer, cleaner in a standardized format? So like I said, very, very, very similar to SIG here on a high level. The variation and consistency was large across all the different drugs. There is a concept called EPN, electronic preferred name. And what this does is, working with the compendia that both the EHR and the pharmacy are using, they will tell you exactly how to build out the naming convention and send it to the pharmacy so that it's clean, it's in the exact same order. So taking the brand name, taking the strength, the milligrams, the route of use, depending if it's oral or ocular or any different thing along those lines, and giving you a very, very specific direction on how to do it. And the end game here is really, how do you greatly reduce the number of variations for the drug? So hopefully that kind of gets through why is it important. And wanted to talk about a little bit of the results that we've seen since we started to do this. And so this is a study over just a one-year period from 2017 to 2018. And from a schematic perspective, I think it's pretty easy to see what's going on, but I wanted to walk through the numbers of what happened here. So from 2017 to 2018, across our network traffic, we saw 30 million new prescriptions on top of the year before. So in 2017, there were 131 million prescriptions across the network. In 2018, we saw 152 million. So we saw 30 million additional prescriptions, but saw some really surprising results. We actually saw about 50,000 less drug names across the network. So you would say, well, Larry, across 1 year, there's more drugs approved by the FDA, and there was about 200 new drugs approved, and there's 30 million new transactions. But because of the effort to standardize into an electronic preferred naming convention, we actually saw a 7% decrease in unique drug names. And so that, of course, is about 50,000 different unique names that were eliminated, of course, across the year. And this really is all due to the EHRs adopting this electronic preferred name, or electronic prescribing name concept. So at this point, we're going to pivot a little bit, and it's time to talk about some of the new transactions coming across the network. And really, we're going to focus on two different transactions. The first one today being what's called RxChange. And RxChange is one of the more revolutionary concepts to come across the electronic prescribing network, really since its inception. And what is it? What is a RxChange? RxChange is the ability for the pharmacy and the prescriber to communicate back and forth with each other in order to make an update of clinical significance for a patient's medication. The way the pathing works is that the pharmacy receives a new prescription from the provider, and something goes wrong. Is it a prior authorization? Is it something that's not on formulary? Or is it, I thought the patient told me, or I thought the doctor told me it was going to be 20 milligrams, not 10 milligrams. So some kind of intervention happens, it's not paid for, it's not what they want, it's too expensive. The pharmacy will now have the ability to send back to the prescriber electronically a request for a change for the prescription. The prescriber will be able to evaluate it, determine if it's something that's appropriate, and send that message back to the pharmacy. So it's a three-step process, but it's eliminating a whole bunch of workflow and safety issues. With this transaction, the pharmacy no longer needs to pick up the phone and call. The nurse no longer needs to enter into the medical record what the question is, and nobody needs to either send a prescription back, fax, call, any of the other manual interventions that have happened previously. And so I look at this as really a revolutionary transaction for pharmacy in that speed, patient access, just the safety gains are really, really important here. One second, my slide will advance. about that. So the second transaction to talk through is CancelRx and the value to the physician. And so this one's a little simpler transaction. It's not a three-step process, but rather a two-step process. So this is doctor's going to increase the dose of medication. Patient had a reaction to something and they're going to be switching to a new medication. Doctor made a mistake and needs to cancel that prescription so it doesn't go to the prescriber. They now have the ability to electronically send what's called a CancelRx transaction to the pharmacy to let you know, hey, pharmacy, we no longer want to be dispensing this. Please cancel it. Please do not dispense it to the patient. Again, trying to solve very much a similar issue, so eliminating phone calls or faxes to cancel prescriptions, enabling electronic workflow. Most importantly, not most importantly, but certainly importantly, is saving time and associated costs. We did a quick study last year looking at one of our mail order partners who was receiving CancelRx's, and the volume was in the millions of dollars saved to the patient of medication goes out, oops, it was a mistake, now you got to come back and pick up a new medication. We've all had to deal with that with a patient where they're paying 2 copays at that point, plus the PBM is also being billed twice. The waste of the system is really huge. So CancelRx is a cost saver, of course, but also a big safety issue. One of the situations I think about a lot is patients who are on warfarin and how often you'd be getting new strengths based on INR, based on how often they're getting their blood work taken. And every week you'd receive a 2 milligram, a 3 milligram, a 7 milligram, a 5 milligram, depending on where the INR was. And, I very specifically remember having a patient with 15 different warfarin prescriptions on the profile, and they'd call you and say, hey, I need to refill my prescription. And, it'd be a 10-minute conversation of what was the most recent one, what was your INR, where do you stand? And this is really where the sweet spot of CancelRx falls. And being able to provide that level of instant, we're stopping the 3 milligram, we're going to the 5 milligram. Now we're stopping the 5 and we're going down to a 2. And so understanding where that is. The second piece to look at here is that many doctors are utilizing other fields to try and do something similar to this. In a recent review of data, we found almost 1% of prescriptions have a free text message saying something to the effect of cancel this medication. That's great. Pharmacists should be looking at the notes field. We all want to do the best there, but I think everybody knows that those fields can be missed. It's just one more thing to look at, one more thing to miss. Of that 1%, 35% of those prescriptions were labeled as high alert or look-alike, sound-alike medication. So even introducing more risk and really trying to figure out what do we do the best thing for our patient. Other things we noticed were dose strength changes, alternate therapy, major changes to patient's therapy that if both prescriptions were on the profile, they could be taking both at the same time, not realizing what was going on. So, I continue to look at that quality improvement, safety improvement areas. These two transactions of cancel and change are absolutely moving our network forward from a patient safety perspective. So where are we today? We talk a lot about these, we talk about improvement, but how are we doing? Are we hitting the mark? Are we where we need to be? I'll start by talking about RxChange. Certainly the metric that we have the most work to do on still, but certainly the metric we've seen the most improvement over the last year. So currently, we have 60% of our prescribers certified to do RxChange and about 40% of our pharmacies certified. So what does certification mean? Certification is the internal process that we go through at Surescripts saying, yes, you've programmed this correctly. Yes, you're able to do this on our network. We give the stamp of approval to go ahead and move forward. From there, they go through a process called enablement. And enablement is the actual turning on. So going into the system, adding that feature and making it happen. As you can see, the drop-off becomes significant here. And largely, this is a time issue, not necessarily a problem with the system or a problem with the transaction. Many of our certification customers have gone through this process very recently, and so we're now in the process of putting in a development to get it turned on within their systems. And as the trickle down comes, obviously the active prescribers, so those who have received the transaction in the last 30 days, is much, much lower. But we expect within the next 3 to 6 months to see this number exponentially climb. How do we make that assumption? I think if you look to the left, the orange bars, you're going to see a very different story. And so pharmacy and prescriber are both greater than 65% certified. Again, that also is climbing very rapidly. But what you're seeing is that enablement curve is very much tighter and a lot closer to the certified. So we have 37% of our prescribers who are enabled and 43% of pharmacies who are enabled for cancel. So that transaction saying, no, I don't want them on this strength anymore. And what does that mean from a volume perspective? We saw 13 million prescribers and 12 million pharmacy transactions in 1 month of January. So you think about that over a course of 30 days, the volume there is changing very, very rapidly. With that being said, I think we have a big hill to climb. And so we'd like to talk a little bit next about where are we currently and what steps are left. And so this right here is our pipeline and what we had for conversations with our customers from an enablement perspective. And so over the next couple of quarters, we're expecting to see large growth, in so much that we're going to see 2019 be a hallmark year for RxChange and CancelRx from an enablement. We really look to our partners to start to be able to see the value. One of the questions we always get when we talk about these transactions is, it sounds great in theory, I've never seen it, what's it going to look like? You play a little bit of a chicken and egg game of trying to make sure that both sides of the network are moving in parallel and really doing the right thing. So I think you're going to see 2019 be one of the years where these transactions hit your pharmacies and you can actually talk through effectively, this is really making a difference for us. And I think we're open to questions.
All right. Well, thank you, Larry. That's a very interesting and informative presentation. We've got a number of questions from our participants. So I'll start throwing those out there. Kind of look forward to your thoughts. The first question is, what is the difference between EPN and using Rxnorm? Yeah.
So they are two factors that work in parallel. And really what the difference is that the Rxnorm is a third safety check. So EPN is the name, and then Rxnorm is very similar to an NDC, where you would have it as a numeric qualifier to say, yes, this is the right concept.
Okay.
And Rxnorm is a value that's developed by NLM, so the National Library of Medicine.
So we've got a question about the 35 points of accuracy that you shared earlier, those measured by Sentinel. Are all those dichotomous variables?
Go ahead.
Yeah, it's kind of a two-parter, I think. And then the other question is a perfect prescription, is that one that meets all 35 points? And if it doesn't meet all 35, does it not qualify as a, quote, perfect prescription?
Yeah, so to answer your first question about the 35, we roll them up into really 11 main pain points, but there are a bunch of what I would say qualifiers. So we would go through a process of checking each of the 35 and then roll it up into a score. And so the way we do it is we create a 1,000-point score for each of our customers on where is their prescription quality. So to define out perfect prescription, it's a little loftier than a check mark on, yes, prescription 3 was a perfect prescription. I think we define perfect prescription more as a concept of, that clean data, being able to be automated, being able to be consumed by a dispensing system, so that minimizing human intervention, minimizing areas of confusion, and obviously just an improvement of patient care overall.
Great. So you come towards the end, you were sharing data on adoption rates for CancelRx, RxChange. So for that and other issues of making improvements in e-prescribing, are there types of pharmacies? Are there pharmacy settings or geographic areas that are underperforming or kind of stand out in terms of making progress in this?
Yeah, there definitely is, and we have the ability to kind of create what we call a heat map and see geographically where these transactions are taking place. I think largely we see it first in urban settings, first in major health systems, major pharmacy chains, because resources are a little easier there. So from a development perspective, getting things built out, they seem to move a little quicker. And I think generally the rural settings tend to lag a little bit just from getting things into their dispensing system. That being said, we definitely see it in both settings, though, and it's a curve that is moving very quickly.
Okay. I've got a question here about quality measurement. So just kind of in light of everything you've presented here, and the potential for e-prescribing to improve accuracy and safety, where and kind of in what areas would quality measurement be helpful for improving prescribing practices?
So I look at it a couple ways. One, there's a lot of access to prescription data through the network. So, we can do trend analysis on disease state or on utilization of medication. There's a lot of opportunities from a quality perspective there. I look at opioids as an area of huge opportunity on trying to identify proper prescribing, trying to identify utilization of MEQs and, high risk. So is it a combination of a benzo and an opioid? I think we have a lot of room for improvement there. I think also just from the program we have with assessing data and how it works, you can do a lot in understanding where are we introducing safety risks. And so, not necessarily from a algorithm output of here's the best practice on a disease state, but from how do we improve the patient safety? And I think that the data does a lot to improve that also.
So on transaction fees, they're often attributed to pharmacies. How can we increase adoption in a fiscally sustainable way?
I think part of it, and there's a few approaches there. One is looking at workflow improvements, and so as there's a cost associated with development or implementing something, is it savings in staffing, savings in number of hours you're on the phone? Is it utilization of patient satisfaction, things along those lines? I think will help balance a lot of that. Certainly what you turn on and which features you adopt, there is some fiscal considerations there. But I think for me, it really comes down to operational efficiencies. And as you make operational efficiency gains, where does that go?
What educational efforts are underway to increase provider awareness of availability and benefits of features such as RxChange, CancelRx, that not only increase efficiencies but also address patient safety?
Yeah, I think it's a great question. We do a few things, and one of it is working directly with the EHR corporations. And a lot of those organizations have much closer relationships with the direct end user. And so educating them on the benefit and educating them on how do you get this out to your user groups. I would say with some of the systems, is they're more open to direct customer contact. We'll do webinars or we'll do educational forums on here's the benefits, here's the results we've seen from using a transaction like this. I think for me, the other really large thing is how do you introduce patient stories? And so it's great to say 13 million transactions in a month, and inherently we all understand that's a big number. But as you try and relate it to a provider level and say, here's where the transaction can save your patient, or here's an area of benefit for you by using a transaction, I think there you get a lot more gains. I think back to the Coumadin and warfarin stories of how do you make it real and say that this is what happens to your patient when you don't use a transaction like this.
And I've got one more here on transaction fees. I probably should have paired these together earlier. Are there additional transactional fee charges to the pharmacy for RxChange communications?
I can get back to you exactly on that, and I think there's a few different models, but generally as an approach, no.
So what are the biggest errors sent by prescribers with eRxs? And then what are the biggest opportunities for improvement when sending eRxs to pharmacies?
Yeah. So it's several different things. One of the areas we see a lot is drug mismatch. And so understanding when the name represents one thing, but the NDC or the RxQE represents something different. And then how does the pharmacy system reconcile that? We see that a lot. The second area is the SIG, because it's a free text field. Anytime you introduce free text where a prescriber can enter things manually, you see a lot more variance. The same is very much true in the notes field, where you might see conflicting directions. You might see them put in diagnosis codes. You might see them put in any different communications with the pharmacy where it might be clinically significant information, But because the white noise in that field grows to a certain volume, often it gets missed by, that's just a coupon in there, or that's just something that we don't want to deal with in there.
So what is the latest with EPCS? How many states require controlled prescriptions, RXs to be sent electronically?
I don't have the exact number in front of me. The last update I had seen, I believe it's around 15 states that are requiring it. The one big thing to think through is there is a federal mandate that's potentially out there in the coming years. I believe it's 2022 or 2025. So there's a lot of movement. There are 5 to 10 state legislators who are considering mandatory bills at this point in time. So it's an area that we're seeing movement on. It's an area we're seeing improvement. There are 3 or 4 states where it is currently a mandatory process, and you're seeing that 70 to 80% threshold where you'd expect EPCS to be, and then there are, the middle tier, and then there's definitely a group of laggers that we're not seeing much progress in.
And SureScript has a EPCS website that I will pass along that we can provide that has up-to-date details on each state individually.
Okay, great. I would be happy to pass that along for you.
Thank you.
So what current data elements that are not required in an ERX is Surescripts considering to include in an ERX for the future? For example, codified indication, ICD-10, SNOMED, codified prescriber specialty, etc.
Yeah, and what I would say that in the new standard, the 2017-071, there's a lot of optional elements that are coming new, and a lot of this is around compound and specialty is where we're seeing a lot. The ones you mentioned are definitely elements as NCPEP defines out the use case we will continue to support. I think for me, the 2 that really stand out most is how do you deal with that specialty world where there's a lot of information that's going to be needed that will be codified for sure. But I would definitely think through those to start.
Okay. Would you be in support of PQA developing quality metrics to measure and track the adoption of e-prescribing technology and their impact on patient outcomes?
I'd say absolutely. I think the opportunity for partnership between PQA and Sharescripts is one that can go pretty much at limitless. And really, whether it's utilization of data to understand, different metrics, whether it's adoption with the EPCS or the 2 transactions we talked about today, I think missions and goals of the 2 organizations align very closely.
You mentioned efficiency gains in ways for pharmacies to justify fees. Is any thought of asking prescribers to pay for a portion of the fees as they benefit from improved workflow and safety issues as well?
Yeah, I think it's a balance there. I think understanding which side of the network is getting the gains and how do you make an economic model that works for everybody. Certainly the goal is not adding additional revenue stream. It's really around that increased efficiency, increased patient safety, things along those lines.
So on the issue of direction concepts and to a similar degree drug naming conventions, what is the status of work to have those standardized across EHR vendors and systems?
Yeah, it's been a slow curve. There's a big mountain to lift there. Currently, our network traffic is about 4% codification. I think this year you're seeing quite a few health systems who are committed to building it. And so several of our large partners have some pilots going on where they're getting it into their base code to make it happen. The struggle here is it's a 2-way side of the network. And so convincing an EHR to send the codification to the pharmacy often requires having a pharmacy that's willing to send it back to them as well. And so as we move forward, it's really a process of creating pilots and creating partnerships where both sides of the network can see the efficiency gains and understand why they're doing it. It's really hard to convince an EHR to do the codification when they're like, we don't see anything out of this. It's our development money, but we're not getting a benefit. So, it's been a process where we've had to work across multiple groups. And, last year we saw about a 2% increase in structured and codified, but, we're looking for that lift to be a lot greater, obviously, moving forward.
CancelRx and RxChange seem to be a dispensing software to EHR transaction. Where do you think Ecare plans can augment that environment?
You know, it's an area I probably don't have as much expertise in. I think there definitely is a room for it in understanding patient care plans and understanding where they play. It definitely is a direct transaction between the EHR and the pharmacy. You know, very similar to a routing of a new prescription. But I think as Ecare plans grow and they continue to become actionable, I think there is some room there for them to play.
So another follow-up on the question of quality measures, you know, to improve patient safety, adoption, do you have thoughts on where focus should be put on measure concepts? Are there areas of care or process that would be, you know, most fruitful for developing measures to improve safety?
Can you repeat that one? I don't know if I caught the question. With concept measures?
You know, yeah, so it's like if you think, you know, quality measures are often broken into three domains: structure, process, and outcomes. So to improve patient safety and adoption, you know, where should focus be put on developing new measure concepts?
Yeah, I mean, I think there's kind of a few areas you can go there, and obviously PQA's approach has largely been around outcomes and patient results, and you know, electronic prescribing data correlates there very strongly. You know, for us, our focus is really around how do we make sure you deliver the most accurate prescription, and certainly plays in the same environment, but it's a little bit different approach. I would say from a competing development resource perspective, it's a balance. We obviously focus very, very strongly on both the pharmacy dispensing system and then also the medical record systems.
Since greater than 40% of prescriptions are abandoned when prior authorization is required, how is RxChange and CancelRx being utilized, you know, to monitor and improve that issue?
Yeah, and I would say it's absolutely a use case in the wheelhouse of RxChange. And so you come in and either prior authorization is required or it's not covered, and many times you either have a formulary alternative listed in the rejection or talking to the patient, you know there's a new request. You could easily send an RxChange to the provider and say, this patient's requiring PA, can we get it something different where it's lower cost and they're not delayed 2, 3, 4 days a week so that access to care is immediate and cost savings is appropriate.
All right, so for our audience, I'll just let everyone know I have one question left in the queue. I'll ask that one, but if anyone has any other additional questions, please go ahead and submit those so that we can address them. So if an ERX is accidentally sent to a wrong pharmacy, is SureScripts considering a mechanism for a pharmacy to redirect a prescription to another pharmacy via NPI and automatically notify the prescriber?
So I don't know that exact approach of what will happen. There is a new transaction in the standard called transfer. So there will be an automatic transfer functionality coming. That's an optional element. So similar to RxChange and CancelRx, something will have to go through an adoption curve, and it'll have to have both pharmacies enabled. But there is an electronic transaction coming forward to there. As per notifying the provider, I do not believe that the standard has anything in there for that piece. You know, there are some options with clinic direct messaging and pieces like that could be a possibility to play in that space, but there will be a new transaction that is coming in the new standard.
Okay, and related to that, in redirecting the prescription, is it possible for that transaction fee to be avoided by the pharmacy that received it accidentally?
In a transfer they would void it, but there's not a standardized, you know, prescriber sent it to the wrong location. They'll have the transfer functionality to get it to the right pharmacy, but there is not an automatic cancel process per se.
Okay. Well, that is all of the questions that I have in the queue. You know, a lot of really interesting dialogue here. Thank you, everyone, for your participation and questions. Larry, is there anything that you'd like to kind of say in closing on balance, given the range and type of inquiries people have had today?
Yeah, I certainly would thank the questions. I think there's some really thought-provoking concepts there around, I look at, as we talk about quality development in those three buckets that were mentioned, and how do we play in that space to make sure that prioritization happens appropriately, and, things from the electronic standard are implemented, but also measures that are needed from other areas of quality are also taken care of. That balance, I think, is a really interesting question. And then I look at, as I kind of have those financial discussions of how does it fit into practice, really understanding the workflow gains and the safety gains and how that drives the practice forward, and where does that play to make sure that the costs associated with a new transaction are offset to make sure the patient's benefit is taken care of.
All right. So, well, for everyone participating today, if you have additional questions or inquiries, you can see Larry's email address on your screen. So he has invited individuals to reach out directly if you have follow-up questions or would like to ask anything related to today's presentation. So, Larry, again, thank you for today's presentation. It's been really informative. And just a quick reminder for everyone else, 3 upcoming events/deadlines. We've got measure development opportunities, another webinar in 2 weeks, and then the PQA annual meeting. And at the close of this webinar, we hope you'll share your thoughts on today's session and also provide us suggestions for future webinars. So thank you again for joining us today, and goodbye.